Welcome to the Deep Dive. Today we are opening the orthopedic playbook to tackle what many of us consider one of the most frustrating, often delayed, and frankly, vexing pathologies we see in highly active young patients. Osteochondritis dissecans, or OCD, of the knee.
It really is a challenge, yeah. And one that demands absolute precision,
Yeah.
in diagnosis and treatment. This isn't just some simple cartilage injury we're dealing with here.
Right.
We're looking at a focal, idiopathic alteration of the subchondral bone, that foundation right beneath the cartilage. And our core concern really is the instability this creates.
Which is a direct path.
It's a direct flight path, exactly, to premature osteoarthritis if we don't manage it correctly.
Right.
So our mission today is, well, to move beyond just the textbook definition and critically evaluate the literature that actually guides our operative decisions.
That structural definition, focal, idiopathic alteration of subchondral bone, it really hammers home the complexity, doesn't it? The pathology is happening right at that subchondral plate, that critical interface, and the subsequent disruption of the overlying articular cartilage is, like you said, the harbinger of long-term degenerative change. It's worrying.
And that complexity, unfortunately, brings us face to face with the reality of our current knowledge gaps. It's something the American Academy of Orthopedic Surgeons, the AAOS, they were sort of forced to highlight in their clinical practice guidelines, their CPGs.
Yeah, I remember reading those. They didn't exactly give us a clear map.
Not at all. They didn't provide us with a neat, evidence-based roadmap. Instead, they essentially served up a list of where the persistent inadequacies in the literature lie.
Mm-hmm.
So we are constantly navigating ambiguity, deciding between extended observation, drilling, or maybe more aggressive fixation, often without that grade A evidence to really back up our timelines.
That ambiguity is exactly what makes treating, say, a 14-year-old high-level soccer player so incredibly difficult. You feel that pressure. We need to define the knowns to try and manage the unknowns better.
Precisely.
So let's jump into the historical foundation and epidemiology of this entity, what Paget first called the quiet necrosis.
Right. When we talk about OCD, we are talking about a diagnosis that's, well, it's defined by a bit of historical confusion, really. The earliest description was actually by Sir James Paget back in the late 19th century.
Okay.
He termed it a quiet necrosis of the bone. And I find that term incredibly evocative, actually.
It is descriptive.
It perfectly describes the insidious, often asymptomatic onset of the disease, before any real mechanical symptoms develop. It just sort of creeps up.
But it was Koenig who actually put the name on it that we still use today, osteochondritis dissecans. And he initially thought it was inflammatory, right? That's where the itis comes from.
Yes, the infamous misnomer that has somehow survived over a century. Koenig himself rejected his own inflammatory theory later on, yet the name just stuck like glue in clinical orthopedics.
It's kind of strange how terminology persists like that.
It's like calling a laptop a typewriter. I mean, it's historically relevant, sure, but scientifically it's just inaccurate based on what we now understand about growth and vascularity. If you look at the basic science literature, or if you talk to veterinary orthopedists who, frankly, deal with this a lot in horses and pigs, they have adopted the more accurate term osteochondrosis.
Osteochondrosis, so acknowledging the growth process failure.
Exactly. It acknowledges the failure of endochondral ossification rather than a primary inflammation. It's about the bone formation process itself going awry.
It's a remarkable disconnect, isn't it? We use the clinical term OCD, knowing full well that biologically it's really a growth disturbance.
Okay, shifting gears to epidemiology then. Recent data gives us a much clearer target profile for screening. What should we really be looking for?
So the overall incidence is cited at about 9.5 per 100,000 children aged 6 to 19. But we have to look beyond that growth number to the risk stratification. It gets much more specific.
Okay.
The risk dramatically increases by a factor of 3.3 for patients aged 12 to 19 compared to the younger 6 to 11 cohort. Wow, 3.3 times.
Yeah. This is that crucial window of adolescent growth spurts and, maximal sports participation. It really suggests mechanical stress is definitely a cofactor applied to maybe susceptible anatomy during that peak growth phase.
And the sex distribution is pretty stark too, isn't it?
Very stark. A male patient has a 3.8 times greater risk than a female patient.
So if a 15-year-old boy comes in with vague activity-related knee pain, no history of a big acute trauma OCD has got to be high on that differential list.
Absolutely. Your clinical index of suspicion must be calibrated to those demographics. You just can't ignore it. And another crucial, often missed clinical point is the rate of bilaterality.
Ah, yes, both knees.
Exactly. While one major series reported a relatively low rate, maybe 7%, other more comprehensive literature places that rate much higher. We're talking ranging from 14% up to a staggering 30%.
30%, up to 1/3 of cases could be bilateral. That's not just an interesting fact. That completely changes our clinical workflow, doesn't it?
It fundamentally changes the required imaging protocol. If you diagnose an OCD lesion in a symptomatic knee, the diagnosis is simply not complete until you have ruled out an asymptomatic lesion in the contralateral knee.
You have to look.
You have to look. If the prevalence is truly closer to 30%, you are potentially missing a significant number of lesions that might destabilize later on if you don't follow up or catch them early. We see textbook examples of this, like the 13-year-old male shown in figure 34.1 in the text, presenting with definitive bilateral medial femoral condyle lesions. We just cannot rely on symptoms alone for screening in this population.
That makes perfect sense, especially when you consider the potential underlying systemic or, genetic components we'll get into later.
Yeah.
Okay, now let's talk real estate. The lesion location seems remarkably consistent across studies, even matching classic data from way back in the 1970s.
Yeah, the geography is pretty consistent. The medial femoral condyle, the MFC, is the dominant location. It accounts for about 64% of cases.
64% on the MFC.
And specifically, we often find it in the posterolateral quadrant of the MFC, that classic spot. This anatomical consistency has really driven a lot of the mechanical theories of etiology over the years.
And the lateral femoral condyle.
The lateral femoral condyle, or LFC, is the second most common, sitting at around 32%.
Okay, so add those up. That's roughly 96% of cases are on the femoral condyles. That leaves less than 4% for those less common, almost unusual spots. The patella, maybe the trochlear groove, or even the tibial plateau.
Exactly. Very rare in comparison.
This strong alignment of typical mechanical stress areas and the common lesion locations really supports the need to scrutinize biomechanics, doesn't it? Even if they aren't the sole primary cause.
That location data leads us directly into the pathophysiology puzzle, which, let's be clear, remains fundamentally idiopathic. We don't have a single definitive cause.
Right, we've thrown out Koenig's inflammation idea.
We rejected Koenig's inflammatory idea, which leaves us searching for the trigger. Is it mechanical overload? Is it some kind of genetic susceptibility? Or is it really a fundamental failure in blood supply down at the bone level? Or maybe a combination?
The most enduring theory, and maybe the easiest one to visualize, is centered on trauma and repetitive injury. Fairbank's hypothesis from 1933 specifically tried to explain that very common MFC lesion.
Right. Fairbank theorized that the lesion resulted from repetitive microtrauma, specifically the tibial spine impacting the posterolateral aspect of the MFC during certain knee movements, may be exacerbated by internal tibial torsion.
You can picture that impingement.
It's an elegant hypothesis for sure, because it explains the specific geography of the most common lesion type pretty well. The mechanics essentially create a localized shear or compression failure right at that spot.
But if that were the sole cause, it would struggle to account for the lesions we see elsewhere, like in the patella or, more commonly, on the lateral femoral condyle. Those don't fit the tibial spine impingement model.
Exactly. That's the major limitation. So how much weight can we realistically put on trauma now?
Yeah.
Well, the reality is that direct acute trauma is only reported in a minority of young patients. The studies range maybe 10% up to 36% at most.
That's a huge range.
It's a very wide range, which tells us that trauma is likely a necessary cofactor in some cases, maybe the straw that breaks the camel's back, but probably not the underlying driver for the majority of patients who maybe have structurally susceptible bone to begin with.
Yeah.
If you repeatedly load a structurally deficient area, well, eventually it's going to fail.
That concept of local biomechanical failure seems strongly supported by that specific link we sometimes see between lateral femoral condyle OCD and the presence of a discoid meniscus.
Oh, absolutely. The discoid meniscus connection is really compelling because it's such a clear instance of altered load transfer mechanics.
It changes how the force goes through the joint.
Precisely. A symptomatic discoid meniscus functions abnormally. It leads to a massive concentration of stress and subsequent overload of the subchondral bone cartilage unit, specifically in the lateral compartment. So it's not just simple trauma, it's a structural anomaly causing localized failure.
And that has treatment implications too, right?
It gives us a key treatment corollary. Sometimes, addressing the underlying mechanical anomaly, like dealing with the discoid meniscus itself, is actually necessary for the OCD lesion to have a chance to heal properly. You have to fix the mechanics first.
Okay, so if trauma and mechanical overload are, let's say, incomplete explanations, We have to look deeper into the structural makeup, maybe the genetic component. There's some pretty strong evidence suggesting familial links, often postulated as maybe an autosomal dominant inheritance pattern.
It's definitely hard to ignore the clear familial clusters you sometimes see. You often find compelling cases documented in the literature, like the siblings shown in Figure 34.2. It shows a sister and brother presenting within about a year of each other with very similar MFC lesions.
That's striking.
It strongly suggests a shared underlying susceptibility that sort of dictates how that subchondral bone matrix forms during endochondral ossification. Something is programmed differently in their development.
Yet, some of the older, larger cohort studies actually show a relatively low rate of associated OCD lesions in immediate family members. How do we reconcile that apparent contradiction with the clear genetic susceptibility seen in some families?
Yeah, that discrepancy suggests a couple of possibilities. Either the genetic penetrance is highly variable, meaning you might carry the gene but never actually express the disease, unless maybe you couple it with extreme athletic activity or some other trigger.
Like the mechanical stress we talked about.
Exactly. Or, perhaps more likely, it's a polygenic disorder involving several genes interacting, not just a simple dominant inheritance pattern. That would explain why it doesn't show up consistently in every family member.
We also have to be careful not to misdiagnose, right?
Absolutely vigilant. We need to distinguish isolated OCD from conditions like multiple epiphyseal dysplasia, MED. ME can present with a similar radiographic appearance, but it's a much more generalized bone disorder affecting multiple joints.
So family history is key.
A family history of short stature or other joint involvement should always trigger a broader skeletal workup, not just focusing on the knee.
This is where I find the insights from veterinary medicine to be, well, incredibly humbling, actually. They seem to be quite a bit further along in defining some of the biological mechanisms.
They absolutely are, largely driven by economics, unfortunately. Osteochondrosis is a huge economic disaster for the livestock industry. It's the leading cause of lameness in horses and leg weakness in pigs. So they've invested heavily in genetic and histological research.
And they've found candidate genes.
They have. They've successfully identified PTH1R, that's the parathyroid hormone 1 receptor, as a strong candidate gene in both equine and bovine models.
PTH1R. So we're talking about a gene that directly mediates endochondral ossification pathways. That points right back to a fundamental failure of bone formation, doesn't it?
Precisely. It shifts the core theory away from just extrinsic forces causing failure toward an intrinsic biological failure of the growth process itself. The core theory that really emerges from these animal models is localized vascular failure.
Back to Paget's quiet necrosis.
Exactly. They have confirmed histologically and with advanced imaging, like contrast-enhanced MRI in bovine models, that a specific area of the subchondral bone fails to receive adequate blood supply during that critical period of conversion from cartilage to bone. This lack of vascularity leads to localized bone necrosis. It's the pathological underpinning of Paget's century-old observation.
It's such an important insight, particularly the note that some of these animal lesions actually resolve spontaneously. That really reinforces the rationale for trying conservative management first in our skeletally immature patients, doesn't it?
Absolutely. We are essentially betting on that remaining potential for biological healing and revascularization in those young patients with open growth plates.
Yeah.
We're hoping their biology can fix it if we just give it a chance.
Okay, so the clinical challenge of OCD, as we've established, is often its very benign presentation, especially early on. This is why we frequently miss it in the early, stable stages, right?
Exactly. The symptoms are often frustratingly subtle. Maybe an occasional limp, some vague activity-related pain, perhaps some stiffness that gets incorrectly labeled as patellofemoral syndrome, or just growing pain.
Things that get brushed off easily.
They do. And crucially, these patients usually lack significant swelling or clear mechanical symptoms like true locking or recurrent effusion, especially when the lesion is stable.
So if the history is often misleading or nonspecific, what subtle physical exam nuances should a resident or anyone evaluating these kids really be looking for?
Well, the physical exam is frequently quite normal, frankly, unless the lesion is unstable or there's a significant effusion present. The key things to look for are really focal tenderness, direct palpation over the medial femoral condyle, particularly that classic posterolateral spot, is an absolute must. You have to push there.
And then there's the classic, but maybe notoriously unreliable, Wilson's maneuver.
Ah, Wilson's,
Yeah.
yes. I remember learning the textbook description. Flex the knee to 90 degrees, internally rotate the tibia, and then slowly extend the knee. Pain is supposedly elicited usually around 30 degrees of flexion and is then relieved when you laterally rotate the tibia. It sounds very specific.
It does sound specific, so why unreliable?
Well, it is specific when it's positive. But here's the clinical reality that often frustrates learners. Multiple studies have shown Wilson's sign is only positive in approximately 25% of cases, even in patients with large, known OCD lesions.
I mean, 1 in 4. Wow.
Its sensitivity is incredibly low. So if you hang your hat solely on Wilson's maneuver to rule out OCD, you're going to miss 3 out of every 4 lesions.
That's sobering.
It is. It suggests the pain mechanism is likely related to the fragment engaging under stress during that specific maneuver, and many lesions, especially those located more posteriorly or smaller ones, simply won't engage in that way. So we use it, sure, but only as maybe a confirmation tool if it's positive, never as a primary screening mechanism. Its absence means very little.
Okay, so since the history can be vague and the exam is often unreliable, that places tremendous pressure on getting the initial radiographic evaluation right. What specific views are absolutely non-negotiable?
The standard series must be comprehensive. You need a good quality anteroposterior, AP, a lateral, and critically, the sunrise view for the patellofemoral joint, and the notch view. That notch view or tunnel view is absolutely essential.
Why so critical?
Because the majority of MFC lesions, remember that 64%, sit in the posterolateral quadrant, which is often completely obscured on a standard AP view due to the overlap of the condyles. Missing an OCD lesion because you skipped the notch view is, well, it's a non-starter. It's unacceptable.
And given the high rate of bilaterality we talked about, maybe up to 30%, we should be advocating for bilateral views routinely.
I strongly recommend it, yes. This isn't just for comparing the symptomatic side to look for subtle changes. It's also vital for ruling out normal ossification variants, especially in younger kids.
Right, the growth plate can look irregular normally.
Exactly. In a growing physis, you can see various irregularities, fragmentation, or islands of bone near the growth plate that can sometimes mimic a true OCD lesion. Comparing it directly to the asymptomatic side is often the best way to distinguish pathology from just normal, maybe slightly irregular growth.
And we need one more X-ray, right, for staging?
Absolutely mandatory. A left-hand radiograph for bone age staging, because the entire treatment strategy hinges on healing potential, which correlates directly with skeletal maturity. Open physes guide us toward conservative management first. Closed physes immediately push us much more strongly toward considering fixation or even salvage procedures.
You mentioned earlier there are new developments in imaging interpretation. Can you elaborate a bit on the structured assessment criteria being developed for X-rays?
Yes, this is exciting work coming out of multi-center research groups. They are defining specific radiographic features that go beyond simply saying, yep, there is a lesion. They're looking at characteristics that seem to predict prognosis. Things like precise location, the status of the growth plate, open, closing, closed, the size of the lesion, any signs of fragmentation or progeny pieces, the quality of the boundary around the lesion, the central radiodensity, and the contour of the articular surface.
So trying to get more predictive power from the plain film.
Exactly. We're moving toward potentially developing a scoring system based just on standard radiography that hopefully will allow us to better triage patients and predict healing potential even before we move to the expense and time involved with an MRI.
Which brings us neatly to the gold standard, MRI. This really feels like the pivot point where we shift from just identifying the lesion to defining its threat level, specifically assessing its stability.
MRI is completely indispensable for that reason. It clearly visualizes not just the bone, but the cartilage integrity, the status of the subchondral bone marrow edema, and crucially, those signs of instability. Historically, the adult criteria for instability were pretty robustly defined by Desmet and colleagues. Those criteria had excellent performance metrics, like 97% specificity, 100% sensitivity, but they were really geared towards mature bone.
Can you quickly remind us of those 4 key adult criteria for instability?
Sure. They look for signs indicating fluid getting in and the fragment potentially separating. Number 1, a hyperintense signal on T2-weighted images, meaning fluid, visible right at the interface between the fragment and the host femur bone. Number 2, adjacent focal cystic areas in the bone. Number 3, a focal defect in the overlying articular cartilage greater than 5 millimeters wide. And number 4, a hyperintense signal line, again representing fluid, that looks like it's traversing both the articular cartilage and the subchondral bone. Those basically define a fragment that is unstable and prone to collapse or displacement.
But as you pointed out, juveniles heal differently, their bone is different, their cartilage is different. So Kajowski and colleagues refined this specifically for the juvenile population.
Yes, Kajowski's criteria are much more tailored to the unique composition of the juvenile physis and the surrounding bone. And, importantly, they achieved equally high sensitivity and specificity in predicting instability in kids. They prioritized features that indicated a failure at that critical bone-cartilage junction.
What are those key juvenile signs?
The two main ones are, first, a rim-like hyperintense signal around the lesion, similar to the adult criteria, indicating fluid equal to joint fluid signal intensity. But importantly, this is often accompanied by a deeper, linear margin of low signal intensity on T2, suggesting the body's attempt to form a sclerotic reparative bone barrier that's failing. And second, finding multiple sites of discontinuity or breaks in the subchondral bone plate itself beneath the lesion.
And what about the ultimate clinical red flag on MRI for instability in a kid?
The cyst. That's the big one. Kajowski identified that finding multiple cyst-like foci under the lesion, or even a single cyst that's greater than 5 millimeters in diameter, is a highly specific finding for instability.
Like we see in Figure 34.3.
Exactly like in Figure 34.3. Seeing a large subchondral cyst adjacent to the lesion basically means that fragment is sitting on an unstable foundation, almost like a water balloon, as you suggested earlier.
Yeah.
While its sensitivity is somewhat low meaning, you often don't see it even in unstable lesions. When that large cyst is present, it is virtually 100% specific for instability. Seeing that large cyst, particularly under an MFC lesion, is pretty much an immediate indication that conservative management is likely going to fail, and the clock is really ticking toward needing operative fixation.
Okay, so once we have the diagnosis nailed down and that crucial stability assessment from the MRI, our treatment goals are pretty clear. We want to save the native bone and cartilage fragment if possible, restore smooth articulation, and hopefully mitigate that risk of early onset osteoarthritis down the road.
Absolutely. And our decision tree is structured almost entirely around those two key factors: the patient's skeletal maturity and that MRI-defined lesion stability.
So let's start with the first phase, conservative management or observation. Who is this for?
This is really mandatory as the first line of treatment for young patients, typically those with clearly open physes on their bone age X-ray, who have stable lesions confirmed on MRI. Their intrinsic biological healing potential is just immense compared to adults or even older adolescents.
And lesion location matters here too.
It does seem to. We generally know that MSC lesions tend to have a significantly better prognosis for spontaneous healing compared to LFC lesions, possibly due to slightly different biomechanical stresses or maybe blood supply patterns.
And we actually have some tools now to help predict success with conservative treatment, right? Like the nomogram developed by Wall and colleagues.
Yes, that nomogram is quite useful because it gives us and the family a more objective metric beyond just a gut feeling or anecdotal experience. It helps predict the likelihood of healing based on factors like the patient's age, the size of the lesion on imaging, and whether they have significant mechanical symptoms like catching or locking. It helps frame the discussion about prognosis.
And what do the results from the literature generally show for conservative treatment success?
The results are actually pretty encouraging for well-selected patients. Healing is reported in up to roughly 50% of stable lesions in skeletally immature patients, typically occurring over an average period of about 10 months.
10 months is a significant amount of time out of sports for a kid.
It is, and that's a crucial part of the counseling. But we must be very specific about what the intervention involves during this observation period. It primarily involves strict activity restriction. It doesn't necessarily mean casting or strict non-weight-bearing restrictions for most stable lesions.
Okay, that's a critical distinction. What does activity restriction specifically mean in practice for a pediatric athlete? Are they on crutches? Immobilized?
Generally, no, not necessarily crutches or full immobilization unless they're very symptomatic. It means removing the high shear, high impact, repetitive loading mechanisms. So absolutely no jumping, no running, no pivoting, no contact sports.
Basically taking away the offending forces.
Exactly. They might be allowed low impact activities like walking, swimming, or maybe stationary cycling, but we are fundamentally eliminating the provocative forces that are stressing that unstable bone cartilage interface. We're essentially putting the lesion in a biological timeout to allow revascularization and healing to occur without constant disruption.
What about things like bracing or casting? Is there consensus on that?
That's where the literature gets fuzzy. The consensus is actually pretty weak regarding specific adjunctive methods like bracing or casting for stable lesions. Some studies use them, some don't, and there's no clear evidence one way is superior. It seems most of the heavy lifting is done simply by removing the injurious activities and giving the body time.
Okay, but we can't just wait indefinitely, especially if the kid remains symptomatic or isn't showing healing. When do we finally decide that conservative management has failed and it's time to switch to the surgical track?
Right, there's a limit. We generally intervene surgically in two main scenarios. First, for those initially stable lesions that remain symptomatic and show absolutely no radiographic or MRI evidence of progressive healing after a reasonable trial, usually a minimum of 3, but more often 6 months of appropriate, compliant, non-operative treatment, including activity restriction.
So failure to progress after 6 months is a trigger.
It's a strong consideration, yes. The second scenario, which requires much more prompt intervention, is the initial presentation of an unequivocally unstable or already displaced lesion. If that MRI clearly shows Kajowski's instability signs, like that 5mm cyst or a clear fluid line breaching the cartilage, that fragment is functionally detached or about to be. Waiting in that situation is detrimental. Prompt surgical treatment is required to try and fix it before it completely displaces, becomes a loose body, and creates a much bigger defect.
Okay, so once we've made the decision to operate and we're in the operating room looking at the lesion arthroscopically, our first job is to confirm that stability assessment visually and tactilely. For that, we need a common, reliable language, right? This is where the validated ROCK arthroscopy classification system comes in.
Exactly. The ROC classification provides the surgeon with reliable, objective descriptors for what we're seeing and feeling with the probe. It replaces vague, subjective terms like sort of loose or looks okay. And importantly, that classification directly dictates our operative strategy. Are we looking at something that just needs healing stimulation like drilling? Does it need mechanical fixation? Or are we already in a salvage situation?
Let's quickly run through those ROCK descriptors as illustrated nicely in figure 34.4. We start with the immobile lesions, where the fragment is, theoretically at least, still attached and potentially salvageable with just stimulation.
Right. The immobile category ranges from the most subtle cue ball appearance, completely smooth, maybe just slight, right, no visible abnormality, and the shadow, a subtle demarcation or color change under intact cartilage, up to the wrinkle in the rug.
Wrinkle in the rug, I like that visual.
It describes it well. You see a buckle or a fissure in the cartilage, but you cannot penetrate it or lift it with an arthroscopic probe. Then there's the locked door lesion, which has definite peripheral fissuring around the fragment, but the fragment itself is completely immobile when you push on it. You cannot hinge it open at all. These categories generally are candidates for procedures aimed at stimulating healing, like drilling.
But the game changes significantly when we move into the mobile categories.
That's the critical threshold. The trapdoor lesion has clearly defined fissuring around it, and crucially, you can probe under the edge or hinge it open like a trapdoor. This is the moment you typically transition from thinking about simple drilling to recognizing the strong need for mechanical fixation to hold it in place while it heals.
And the worst-case scenario?
That would be the crater. This describes an exposed, unsupported subchondral bone defect, usually because the fragment is completely loose, maybe floating elsewhere in the joint as a loose body, or has been ground down. When you encounter a crater, you are now squarely in the realm of complex salvage procedures, because there's nothing left to fix in place. That ROCK score we assign intraoperatively is essentially the map that directs our entire technical approach for the rest of the surgery.
Right, let's dive into the surgical techniques themselves, starting with the least aggressive option, usually indicated for those stable, ROCK immobile lesions that failed that 3-6-month trial of conservative management, drilling. The objective here seems purely biological, right? To bypass that avascular sclerotic rim of bone at the base of the lesion and introduce crucial biological factors and blood supply from the healthy adjacent cancellous bone.
Precisely. Drilling is all about creating vascular access channels to promote healing. And we have 3 main ways to do it, each with its own distinct technical trade-offs and advantages.
Okay, let's start with transarticular drilling. The advantage seems undeniable. You have direct arthroscopic visualization. You can see exactly where the lesion is and precisely where your drill wires are going into it.
That direct visualization is definitely the main advantage. You know you're hitting the target. But the inherent disadvantage is that you are intentionally violating the overlying articular cartilage surface, even if it looks intact.
How do we minimize damage there?
We use very small, smooth Kirschner wires, usually 0.045 inch or maybe 0.062 inch wires. The goal is typically to make about 6 to 10 passes, spaced a few millimeters apart, making absolutely sure they cross that sclerotic margin visible on MRI and penetrate into the healthy, bleeding subchondral bone beneath. It's effective, yes, but we have to acknowledge that those microchannels we create are minor defects in the articular cartilage surface that we hope will remodel smoothly over time.
Which is exactly why retroarticular drilling from behind the lesion, is often favored by surgeons who are particularly concerned about any disruption of the cartilage surface, especially in a critical weight-bearing zone. It preserves the articular surface entirely.
It does preserve the cartilage, which is a massive theoretical advantage, no question. However, it is significantly more technically demanding for the surgeon. It absolutely requires precise fluoroscopic guidance, which means radiation exposure for the patient and everyone in the OR to ensure the drill trajectory hits the target progeny bone accurately without violating the joint surface from the deep side. As you can see in the example fluoroscopic view in figure 34.5, getting that angle just right, especially with posterior lesions, requires real discipline and spatial awareness.
It definitely seems like a higher technical hurdle for the surgeon compared to just drilling what you see. What are the risks?
It is technically harder. The risks include missing the lesion entirely if your targeting is off, drilling too deep or penetrating the joint inadvertently from behind, or maybe not getting enough passes into the lesion base. But the potential payoff is significant, and the reported results support the effort when done well. Gundin and colleagues reported an impressive 86% healing rate at an average of just 5.6 months using this retroarticular technique. So if you can perform it safely and accurately, it's arguably the superior technique for that stable, non-healing lesion where the cartilage is still intact.
Okay, and the third drilling option, notch drilling, feels like maybe a compromise between those two extremes, trying to avoid the main weight-bearing surface, but maybe easier than retroarticular.
That's a pretty good way to put it, yeah. Notch drilling aims to enter the femur through the bare area of the intercondylar notch, which is generally considered non-articular or at least minimally articular cartilage. The idea is to thereby minimize violation of the primary weight-bearing surface of the condyle while still getting relatively direct access.
What's the limitation?
The main limitation is simply access and trajectory. For larger lesions, more anteriorly located lesions or lesions deep on the lateral femoral condyle, the notch simply won't give you the angle or the coverage you need to adequately drill the entire base. It's often only suitable for a relatively small, well-located subset of posterior MFC lesions.
Okay, so once we transition past just trying to stimulate healing with drilling, we move into the realm of fixation. This is generally reserved for those unstable but still salvageable fragments like the ROCK trapdoor lesions we see illustrated nicely in figure 34.6. Here, the goal requires reliable mechanical stability to allow the fragment to heal back to the underlying bone bed.
Stability becomes absolutely paramount at this stage. We need enough compression and rigidity to hold that fragment anatomically reduced and firmly compressed against the prepared recipient bed to allow for primary osseous union, ideally. The historical gold standard here remains metal fixation.
What kind of metal hardware?
Typically, we're using things like small cannulated screws or variable pitch compression screws, like the classic Herbert screw design, which can be buried beneath the cartilage surface.
These definitely offer reliable, strong compression. We know they work. But the major clinical drawback, especially in these active young patients who might have decades of activity ahead of them, is the very high likelihood of needing a second surgery just for hardware removal.
It's almost always the guaranteed second trip to the OR, unfortunately. If those screw heads are even slightly proud, or if they become prominent as the surrounding cartilage potentially remodels or settles even by a fraction of a millimeter, they pose a significant risk of scuffing or shearing the opposing tibial cartilage with every single cycle of knee flexion and extension. That's unacceptable iatrogenic damage. So, to prevent this, we often plan to remove them routinely, usually around 6 to 12 months post-op, typically after we have radiographic or maybe even MRI confirmation of solid healing.
And implant material matters for follow-up.
Yes. We generally prefer titanium implants over stainless steel these days, mainly because titanium causes significantly less artifact and interference if we need to get a post-operative MRI to monitor the healing status of the bone and cartilage.
This inherent need for removal with metal is what leads us to the strong appeal of biodegradable devices, pins, rods, or screws made from materials like polylactic acid, PLLA, or sometimes newer magnesium alloys. The theoretical advantage is obviously huge. get rigid fixation initially, but then the hardware just dissolves away, avoiding that second removal procedure entirely.
It is the ultimate clinical temptation, isn't it? We all want to avoid putting a kid through a second anesthetic and another OR trip if we don't have to. However, the clinical reality, based on years of experience and literature now, is that the complication profile for bioabsorbable hardware can be, well, messier.
What kind of problems can arise?
We have seen risks of the device breaking before healing is actually complete, leading to loss of fixation. We can see the formation of sterile cystic lesions or tunnels in the bone around the dissolving hardware. And furthermore, the slow degradation process of the material itself can sometimes trigger a significant foreign body immune response in the joint, leading to aseptic synovitis, persistent pain, and effusions that often require, ironically, a surgical debridement and removal of the dissolving fragments anyway.
So it really is a trade-off then. You have the guaranteed second surgery with reliable metal versus a small but definite and potentially more serious risk of a biological or mechanical complication with the biodegradable device that might also end up needing surgery.
That's exactly the calculation. You are essentially gambling known reliability and a planned second procedure against the convenience of avoiding removal, but accepting an unknown, albeit probably low risk of a potentially much worse complication down the line. And in a young joint that needs to function perfectly for maybe 50, 60, 70 years. That's a heavy calculation to make with the patient and family.
We also briefly touched on the concept of biologic fixation techniques earlier, which seem to try and couple structural support with actually enhancing the biology of healing.
Right. These are interesting methods that use biological material itself to stabilize the fragment, hoping to integrate better. Miniachi and Tytherley Strong, for example, described using autogenous osteochondral grafting, taking cylindrical plugs of bone and cartilage from a non-weight-bearing area, like we do for mosaicplasty, but using them almost like long pegs or biologic screws, inserting them through the unstable OCD fragment and into the healthy subchondral bone beneath to pin it in place.
And Navarro's technique.
Navarro describes something similar using autologous bone sticks harvested as cortical cancellous dowels from the patient's proximal tibia. The idea is that these provide not just structural scaffolding, but also bring local mesenchymal stem cells and osteogenic potential right to the fracture site to enhance healing. However, both of these are technically very demanding procedures because the graft trajectory, length, and fit had to be absolutely perfect to provide stable fixation without damaging the fragment.
Okay, finally, we have to address the last resort category, the salvage procedures. This is what we turn to when the native fragment is deemed unsalvageable. Maybe it's completely loose and fragmented, maybe it's lost entirely, resulting in that ROCK crater defect. The key principle here, as you mentioned, seems to be that simple excision or debridement alone is inferior, and you absolutely must address both the articular cartilage deficit and the often significant underlying subchondral bone loss.
That's the crucial concept for salvage. If you only try to restore the cartilage surface, maybe with microfracture or ACI, without first restoring the subchondral bone stock underneath, your cartilage procedure is almost doomed to fail due to lack of structural support. It'll just collapse into the defect. This is why simple microfracture or other marrow stimulation techniques are generally relegated to producing inferior results in most OCD lesions compared to other techniques. While they can generate some fibrocartilage repair tissue, the depth of the bone loss usually means that fibrocartilage just can't withstand the compressive and shear loads in the knee long term.
So, marrow stimulation is usually not enough for these deeper defects. Therefore, we move to procedures that replace bulk tissue, starting with osteochondral autograft transplantation, or OAT.
Right. OAT, which is often referred to commonly as mosaicplasty, uses those cylindrical osteochondral plugs harvested from a non- or low-weight bearing area of the patient's own knee, usually the periphery of the trochlea or the intercondylar notch.
Yeah.
It's an excellent concept because it restores both the bone defect and the hyaline cartilage surface simultaneously using the patient's own living tissue.
How well does it work for OCD?
It works very well for small to medium-sized OCD lesions, providing good results. However, multiple studies have shown that its effectiveness starts to deteriorate pretty sharply if the lesion size exceeds about 6 square centimeters.
6 square centimeters, that seems like a fairly clear threshold. Why that specific size limit? Is it about coverage?
It's mostly about the donor site. That size, roughly the size of a large postage stamp, as you said, represents a practical limit of how many plugs you can safely harvest from the typical donor sites within the knee without causing significant pain, effusions, or potentially long-term problems at the donor site itself, what we call donor site morbidity. While donor site issues might be slightly less severe in young patients with good healing potential compared to older adults, you still can't just take an unlimited amount of tissue without risking creating a new problem where you took the grafts from. So that harvesting limitation restricts our ability to treat those really massive full condyle with displaced lesions with autograft alone.
Okay, so for those really large defects that exceed the practical limits of OAT, or maybe when the surgeon is particularly wary of any donor site morbidity, even for smaller lesions, we then have to look towards using fresh frozen osteochondral allografts.
Exactly. Allografts, using tissue bank donor bone and cartilage, are really the heavy artillery for treating those large, massive defects, often greater than maybe 8 or even 10 square centimeters. Figure 34.7 in the text really illustrates the complexity and scale of implanting one of these large allograft plugs. The advantage is obvious. No donor site morbidity for the patient, and we can get a large enough piece of tissue, often pre-shaped, to match the defect size and surface curvature almost perfectly.
But there are downsides, right? Concerns about using donor tissue.
Yes, the disadvantages are significant and center mostly around logistics and biology. There's the viability of the chondrocytes within the graft after the freezing, storage, and thawing process, how many cells actually survive to maintain the cartilage matrix long term. There's the very small but real risk of disease transmission from the donor, although screening is rigorous. And there's always some biological concern over how well the host bone will integrate with the allograft bone and the potential for a low-grade immune response to the foreign tissue.
Given those potential biological concerns, what kind of longevity can we realistically expect from a fresh allograft in a young, active patient? Are these durable?
The results are actually quite encouraging, surprisingly so perhaps. Emerson and colleagues, among others, have reported quite good medium-term survivorship. For instance, one study reported a 5-year survivorship rate of 91% for large osteochondral allografts used for OCD. This suggests that when utilized appropriately for these challenging large defects, particularly those that have failed primary fixation attempts, allografts offer a highly viable salvage option for restoring the joint surface and hopefully buying the patient significant time, maybe decades, before a total joint replacement might eventually be needed way down the line.
Okay, that leaves the final salvage procedure we need to discuss, perhaps the most biologically sophisticated but also complex, autologous chondrocyte implantation, or ACI.
Right, ACI is a fascinating technology that allows us to use the patient's own chondrocytes, harvested during an initial arthroscopy, expanded in a lab over several weeks, and then reimplanted under a patch or onto a scaffold to repair the cartilage defect. It has some of the best long-term survivorship data available for cartilage repair, with studies showing good results extending over decades in some patient cohorts.
But it sounds logistically challenging and expensive.
The logistical and cost disadvantages are definitely substantial. It inherently requires 2 distinct surgeries. First, an arthroscopic biopsy to harvest the cartilage cells, followed weeks later by the open or arthroscopic implantation surgery after the cells have been cultured and expanded.
And critically, ACI primarily addresses only the cartilage layer, right? So if the patient has that significant underlying subchondral bone deficit from the OCD, ACI isn't the primary or sole solution, is it?
Precisely. That's a key limitation. If there is significant bone loss, that crater defect in the ROCK classification, you absolutely must perform some form of bone grafting procedure first, like using autograft or allograft bone, to create a solid, stable foundation. Only then, perhaps in a staged manner months later, can you come back to perform the ACI procedure onto that reconstructed base.
Have the techniques improved?
Yes, the modern ACI techniques, particularly those utilizing newer collagen matrices or scaffolds to carry the cells, often called MECI or matrix-associated chondrocyte implantation, have thankfully reduced some of the historical complications, like periosteal flap hypertrophy or delamination, that plagued the earlier generations using just a periosteal patch cover. But even with these advances, ACI remains an expensive multi-stage procedure that's generally best suited for younger patients with relatively contained full-thickness cartilage defects who have good underlying bone stock, or who have successfully undergone bone grafting previously to address the subchondral pathology first. #outro for you.
Wow, this has been a really rigorous review of a complex topic. So synthesizing all these steps, it seems clear that the management of juvenile OCD, this focal idiopathic condition, is absolutely dictated by 2 main factors: the patient's skeletal maturity, which tells us about their healing potential, and the lesion stability, which we primarily quantify using those advanced imaging criteria like Kajowski's refinement for MRI.
That sums it up well. And our clinical reality, despite all these techniques, is that the field still desperately requires better evidence. We have some impressive technical strategies now, certainly, but we still need more well-designed multicenter trials and large prospective cohort studies to truly define long-term outcomes, especially comparing these different approaches head-to-head. We need to know which intervention not only fixes the immediate problem, but genuinely mitigates that decades-long risk of premature osteoarthritis for these young patients.
Which brings us perfectly to our final, very practical clinical question for you, the listener, to consider as you prepare for your next OCD case review or surgical planning. The fixation strategy itself often feels like the crux of the dilemma, especially in that skeletally immature patient with an unstable but salvageable lesion. Given the spectrum of available options we discussed, from simple drilling hoping for healing to metal screws, bioabsorbable implants, or even biologic fixation, and acknowledging the varying results and potential complications, which choice truly offers the best blend of immediate, reliable stability that's needed for osseous healing?
Is it that metal screw that gives you guaranteed rigidity and compression right now, but almost certainly necessitates a second anesthetic and trip to the OR for removal down the line?
Yeah.
Or is it perhaps a state-of-the-art bioabsorbable screw, which promises to spare the patient that second surgery, but carries that small, yet finite, potentially serious risk of device breakage, inflammatory reaction, or fixation failure that could lead to a far more complex joint catastrophe?
That risk-benefit calculation, predictable metal versus potentially problematic bioabsorbable, it's not just a scientific formula, is it? It feels more like the art of medicine, balancing immediate certainty against decades of unknown biological response in a growing knee.
It really is. And anticipating that decade-long joint health trajectory rather than just focusing on solving the immediate defect we see on the scope remains the ultimate challenge and maybe the most important responsibility in managing juvenile OCD effectively. Something to really think about.